PHI's first live Ask the Doctor session. Um, some of you who are joining us from Michigan might have probably done this before with Dr. Maynard. It's always gone great before, and Dr. Maynard's a great guest. Got a wealth of knowledge that he has generously agreed to share with us, and we appreciate his time today. This will be a continuing monthly series with a rotating series of health professionals joining us. So today's Dr. Maynard. In February, we'll have one featuring Dr. Yulberg. So keep an eye out for that. We will send out an email. We'll also put a notice in the newsletter. So as we asked people to send in their questions prior to today's session. So we will get to those first. And if we have time left at the end, we'll take questions live. And you can either use the raise hand feature, or you can go ahead and type it into the chat. Either way is fine, and we'll try to get to as many as we can. When we do get to your question, feel free to flip on your mic. But otherwise, we ask that everyone stay muted during the session. I think that's about all the housekeeping items I have. So I guess without further ado, let's get started, and I will hand it over to Dr. Maynard. Fred?
Thank you, Brian. Good afternoon, everyone. We hope you're all staying warm. That's what we were just chatting about that. But fortunately, we're all in nice warm houses, I hope. And welcome for this. We hope to have a larger audience and be able to have PHI members and friends throughout the country participate and have questions answered. And if we get through the questions and we have time, we may have some of the oral questions that move into discussion. And that would be fine as far as I'm concerned. As you know, polio continues to get a little press in the news because of the questions that have been raised by President Trump's nominee for Health, Education, and Secretary, Robert Kennedy Jr. And so that it's interesting because that does keep the topic alive and remind more people that polio survivors are still around. And we're not particularly impressed by people that are saying that vaccines are not effective and are overly dangerous when we're concerned that we don't have another outbreak in our country. And I did have one submitted question that maybe I'll start with, just because it seems timely from that standpoint. But one person did submit a question ahead on vaccines. And it was, let me see if I can find it now. Oh, yeah, it's our friend Kathleen Casey. And she said that an 80-year-old friend of hers recently mentioned that they had been revaccinated for polio. And her doctor had recommended it as it had been so long. I mean, basically over 70 years since her last Salk injection, obviously when she was a child. Kathleen says, I understand there are new strains of the virus evolving over the years. Is this necessary or a good idea to be revaccinated? I have thought that was a question that took me a while to reflect on. And I would have to say that it probably is not necessary. We would not really recommend it or consider it necessary, with two provisos. One is the exception of if a person were to travel overseas to one of the places where polio is still endemic, such as certainly Afghanistan and Pakistan, possibly some of the areas in equatorial Africa, or other places where there was known to be an outbreak. Usually those are war zones. Those are the times when it would be worthwhile. Now, I'm presuming there's not very many polio survivors, hopefully, that are going to those places at this moment in history. But if they were, then probably it would be a good idea to be revaccinated. The other one that people could consider at times is if someone has a disease that affects their immune system in a way that may leave their previous immune system's response to vaccines incompetent or changed. And even then, if you're not around, again, in these areas where you're going to be exposed to it, it still may not really be necessary. But I suppose, and then the other issue, if your immune system's compromised, you may or may not respond to the vaccine when it's given. So it's kind of that's a gray area, but I certainly wouldn't criticize anybody if they felt they just worried too much without without taking it. So that's the way I would generally answer, that question. I don't think you have to re-worry about it at this point in time. Okay, going on. I'm going to go with some of the questions in the orders that they were submitted. The first one I'll start with was submitted by Martha Hodge-Smith. I don't think I know Martha, but if you are here, say hello. No, maybe she doesn't want.
She was able to make the call. Yeah.
Oh, maybe well, if she's on the call, maybe we should wait in case she comes late.
We could do that, sure.
All right, I'll go ahead then. How about Greg Plut? I'm not sure how to say his name. PT Ptupa.
Yes, sir.
There you are.
Present and counted for.
Very good. I guess we met in Colorado, you say, at the 2016 retreat.
Yes, many moons ago.
Wonderful memory. Greg tells us that he's 73 now, had his polio in 1953 at age of 1. And it was apparently primarily affected his left lower leg, particularly below the knee, with a lot of muscle atrophy. And he received some massage therapy sessions from the visiting nurse in preschool years, and then had extensive surgical and bracing treatments as a child and teenager that included wearing heavy metal braces on his lower left leg. But by college, he was able to get rid of the brace, or I guess maybe it was the end of high school, 10th grade. He was able to eliminate the need for the brace because of this. I presume it was probably an ankle fusion that required several stages to be done. So then he goes on to say that throughout college and his professional career, until about 5 years ago, that he had walked and bicycled to work, also biked and walked errands and trips, that he once did the Seattle to Washington, D.C. cross-country race in 1982, and another one along the Mississippi River in the late 80s. So you were quite a biker, I guess. And he said that was possible because his left thigh, the quadriceps and hamstring muscles in the thigh were very strong, and so he had no difficulty biking. But over the last years, beginning in about 2016, so that's about almost 9 years now, 8 or 9 years, the left leg has been gradually weakening. And he notices it, of course, first in the harder things like biking, stair climbing, and walking longer distances. So the last 2 years, the pace of the increasing weakness seems to have picked up. So he's now using walking sticks for distance walking and some new bracing to stabilize his knee, because the knee is wanting to slide sideways when he's walking distances with it, putting his weight on it. And the stairs are becoming more and more of a struggle. Sound familiar? It does to me. I've heard that similar story many times, Greg. So his question is now nicely stated. It's a good question. Are there orthopedic surgical options to stabilize my now unstable knee? My good orthotics consultant said that the knee loses stability when muscles that support it have weakened. Since I never had muscles below the knee, the now diminished strength in the quadriceps and hamstrings of the thigh seem to be precipitating the knee instability. Greg, I would agree with your thinking. In the orthotist, it is true that as the thigh muscles weaken, they do contribute, even in normal. I mean, people that don't have any polio weakness problems, just getting older, perhaps less active, but and weaker. Knee instability becomes more common. The primary stabilizing forces on a healthy knee even when you're young is in the muscle. That's why anybody who's going to be an athlete that in like tennis players or skiers that where their sport involves a lot of twisting, always emphasize that they really have to work very, very hard on strengthening their thigh muscles. So your analysis, I'm afraid, is probably correct. The other factor that fits into this is as we get older, we lose the cartilage in our knees. That's why so many people develop osteoarthritis of the knees as we get older, including myself. So I know this subject quite well on a personal level as well as a professional level. And when you lose your cartilage, the space between the two bones of the knee, the femur and the tibia, becomes smaller, okay, because the cartilage is gone. So that leaves the ligaments on the side of the knees loose, okay, because they're not as tight because the space underneath is less. So that's another contributing factor to why they tend to want to slide sideways when you're putting a weight on them, particularly if your muscles aren't strong enough and shortening. The muscles will shorten with that space, but ligaments tend not to very easily. They stay stretched out. So we end up with these loose knees. Well, relative to, and I guess one question I would have to you before I go on to say what I think are your best options to manage this, I'm presuming you have pain in the knee when you're walking now because of that sliding forward. Is there much pain or just a little bit?
It's very occasional and it's not a chronic problem at all. It's actually just the awkwardness of the knee wanting to go laterally when I want it to not do that.
Okay. Well, that's reassuring then, because you're lucky, I think, because a lot of people that can become quite painful. You must have at least not very much inflammation then in the ligaments as they're being stretched out. In that case, but to get to your question is what can be done about that? I'm not aware of orthopedic surgical procedures being done to tighten ligaments in people in your age group. They don't tend, after all, when you cut into a ligament, it's going to end up scarring. And people tend not to want to do that because it's been tried and it frequently leads to more problems than you started with. Therefore, if it gets to the point where it's limiting that actual movement rather than an annoyance, I think the simple thing to do is, if you haven't tried it, as an alternative to, you can always correct that if it gets bad or too painful with a long brace, but they're very cumbersome, of course, to be able to wear. They'd have to connect all the way to the shoe. And a simple way is sometimes just one of the knee sleeves that has hinge joints on the sides. And to wear those when you're going to go a longer distance, or you're trying to hike on unlevel ground, or perhaps your longer bike rides, if you're still doing that.
I actually have one of those.
Those
It's
are
a recent acquisition. And one of those plastic ones that goes from the below the knee into the shoe.
anything that
I don't know what they're called.
yeah. There's probably a variety of those that I'm not even aware of all of them, but they would be a very sensible thing to do because if you go to see an orthopedic surgeon about it, they'll offer you a knee replacement. You know, certainly that's if you do a total knee, put in a new artificial knee, it'll be stable. But when you still that will weaken your muscles some. Especially, you know, I mean, some people they can get it back after the surgery, but you're gonna, you know, you go through a major trauma, there is some strength reduction, and since you're already dealing with the major problem being a weakening in the thigh muscles, you don't want to do that unless you're looking for a really major pain relief. And so I think it's probably reasonable to deal with using sticks for long distances, using some of these smaller braces, and waiting it out. If I'm wrong, there might be some orthopedic surgeon who thinks he's got a brand new hot procedure that I'm not aware of yet with some brand new techniques, but I think I'd be very skeptical and want to talk to some of the people who've gone through it before and take a critical look at results before I would take that chance.
Well, thank you. I really didn't expect much of a different response, but I appreciate it.
It's a good question. Okay, Arthur Lieber, are you with us? Arthur's not on.
He is on the call, Fred. Yes.
Oh, is he on the call?
Here I am. Thank you.
Oh,
Sorry about that. Thank
Hello,
you.
Arthur. Yeah, it's a good question. Arthur says, I'll just share your question with everybody so they can follow the answers. I'm 77 years old. I had polio when I was 5, and the post-polio syndrome that began in about 2 years ago. When he had polio, he reports that his left arm and left leg were both paralyzed, and the paralysis has recently begun to come back in his left arm 2 years ago, but had not significantly done so in his left leg. And so he's asking, should I expect that the left leg will become increasingly immobile? You know, I'm presuming your question, not to fuss about words too much, Art, but I think it would be your left leg becoming increasingly weaker. Hopefully not mobile. Okay.
Okay.
That it doesn't so weak that you can't move it at all. But can I ask you the question? How old were you? You said you were 5 or
5, yeah.
So from the best of your memory, or you know, the years shortly thereafter, how severe was the weakness in your left arm and your left leg? I mean, like, were you still able? How long did it take to learn to walk again?
Yeah, my recollection is that I was in the hospital for about a week, and that by the time I left, I had most motion back in my arm and my leg. I don't remember having braces for my leg. I don't know whether or not I ever was in an iron lung. I don't think so.
Well,
But um, it was one of those things where the left arm just really just kind of got locked. And then as I got older, actually rather quickly, I was able to move it, maybe having 95% of the strength that I do in my right, and same with the leg. But with the arm, right now, I cannot lift it any higher than this.
okay, yeah. So it's a lot
Yeah.
of shoulder weakness in particular, right?
Right. So, if something comparable would happen with my leg, I would be rather immobile.
Well, hopefully not, but because
Yeah.
there's a lot of other things that can be done, remember. But I would say that, you know, certainly you are, if you had that history as a child where you involve both of them, I think the chances, are reasonably high that your leg may start getting weaker. It's unlikely to get severely weak all at once. It's a
Right.
gradual kind of thing. And if you're staying able to stay active with using it without overusing it, with honoring your signs of fatigue, you may not see it. You know what I mean? Maybe it's there, but it's not significant. Most of us change our lifestyle enough as we get into our 70s and 80s or more that we're not putting quite as big a demand on them as our muscles, so they can lose
Right.
some strength without it being a significant functional problem for you. So
Thank you.
that would be the way I would basically look at it. Don't just be aware it may happen. Don't let yourself think about it too much, and be overly concerned about it. But on the other hand, if you start noticing any signs of it, and the first ones that you usually notice are things like climbing stairs, more trouble standing up from sitting to standing.
Right.
Those are the type of things that you'll see first. And if you do, that's where doing some gentle exercises that are non-fatiguing and not, that are not followed by symptoms of pain or weakness are still good. Okay. Because they can postpone that day that it may get weaker yet. The arm, I
No.
don't know what to tell you. I guess are you certain you've not had pain problems through your neck and arm to
Well,
look?
I did about 5 years ago and had the disc removed, I think between C5 and 6.
Yeah.
And the pain went away, but the motion didn't come back.
Okay. And that may be a secondary type of issue because the shoulder joints, as we get older, are pretty fragile, I guess I'd say.
Right.
They're so complex and a lot of things go wrong with them. And then, yeah, so having the neck problem and not being able to use it or be as active with it, and they have maybe having some nerve damage that was weakening it, then you don't get it back, even if the problem is taken care of. It never comes back fully.
Yep.
So that's a good sign that maybe the leg issue won't come to the same degree.
Maybe if I could real quickly say something cautionary. I found that when my left arm became rather immobile, um, I did not adjust well to what that was doing to my balance. And so I've had a couple falls, in part because I can't put my left arm out to try to regain, or as I had regained my balance when I was younger.
Ah, okay. Well, if your other arm is good,
Yeah, it is.
use a good walking stick or a cane when you're going to be in any kind of
Okay,
hazardous situation like we're all dealing with the ice and snow.
got it.
If,
Thank you.
so and I was just going to take off from that because I'm going to follow your question by one from Tim Brown here, because they both deal with this question of really the progression of post-polio syndrome. And so even in answering your question, or as I'm approaching Tim's question, let me remind everyone that there is no totally predictable way to say how much at risk and to what speed post-polio syndrome is going to come on for people and how severe it will be. There's a couple clues, okay, that I can mention, but none of them are terribly reliable, nor have they been studied from a scientific standpoint enough to put a lot of confidence on their predictability. So we just kind of are more look at the risk factors for it progressing and then being aware of early signs of that so you can take steps to alter behavior or do some new things at the first sign of them. And that's your best general approach to the problems of progression or how to anticipate and not overly anticipate progression. So Tim Brown, Tim, you're asking here again. I'll read your nicely worded question. You're very good at this. Tim is saying that he's experienced declining physical abilities due to post-polio syndrome for about 30 years. For those of you that don't know Tim, he's been associated with the Michigan Polio Group for at least 30 years or more. And so he's well versed in it, and he's been our major tech support person for the Michigan Polio Network. He notices that it always seems that he would encounter a noticeable drop in strength, followed by a long period of no decline. And then he would lose more ability again, which would again be followed by a period of stability. So after reflecting on this long view of over 30 years of dealing with PPS, he states that the periods, to him, it appears the periods of stability have become shorter. And so he's asking me, based on my experience of treating polio survivors for the last 40 years or whatever, it's been 45 now, I guess, is this trend of accelerating decline to be expected? In other words, with each of these bouts where you start feeling some new weakness, it seems like it's a more severe weakness, and the interval between when it was stable and when it again was starting to decline has become shorter. You know, Tim, I think your impression is that they are, and you know, mine is too. And there's no data on this, so it's, you know, it is hard to say. But I would agree with that general impression that a person who's had 30 years of stepwise downhill, it is going to probably become seemingly more severe. Now, remember, when I say seemingly more severe, how do we measure severity? You know, is it by the percent loss of total maximum strength of the muscle? Or is severity is more commonly measured, I think, by most people, late people that have the polio, and professionals in rehab like myself. Severity is more commonly when you cross a threshold of functional change. So when the strength may just be declining in these, you know, every period of interval, you tend to notice it when it's a 10% or 20% decline, something in that order of magnitude. But if that 10 or 20% decline takes you from being able to walk without a limp or without feeling precarious when you're on unlevel ground, then you're going to notice it. It feels more severe than when you have a 10 or 20% loss that doesn't make an obvious change in your functional ability that requires you to do something different, other than maybe not go as far, not going as fast. So it doesn't feel as severe. So that would be my only other caveat, I think, to your observation that most of the studies, you know, it's again, how do we measure this decline? Because you're not measuring it on a day-by-day basis, and nobody's strength is exactly the same day by day. Other factors come in. But I remember one patient one day that I had many years ago with an older woman. She was, she seemed old at the time, but now she's like our age. She was 80 or something, and she was a youper when I was down in Ann Arbor. And she lived alone in a very rural, isolated area by herself, and probably an old tough Finlander. And one day, and she'd been struggling for some time. She didn't, but to her, she just took that all in stride, so it didn't seem severe. And then she said, literally, one day she woke up and she couldn't stand and walk. So it appeared extremely sudden. And she got sent down all the way down to Ann Arbor, and nobody could really come because they couldn't find a stroke or anything else to explain why she had suddenly lost the ability to stand and walk. And when we heard this story and met her and studied her, we got around to doing an electromyographic study on her leg, the critical muscles in her leg, like her quadriceps muscle. And what we found was she only had 2 motor units that were functioning in that leg. And when we, and they were huge, giant motor units. And our impression was that she may have crossed the threshold from something like 4 or 3 motor units to only 2, but each one was contributing 30%. And so when 1 unit was lost, it made a huge difference. It took her over the threshold where she no longer could stand up and even take a step by herself. And yet it was, normal. Maybe you guys, I need to remind you that a normal muscle of that type would have several hundred motor units. If you had a severe case of polio, maybe you lost half of them. And so you had 100 left, but they all got bigger, partially larger. They could do more. So you could function. You didn't notice it. You didn't hardly even know you'd lost 100. Well, she may have lost something like 80% of what she normally had, because she had been severely weakened, all her life. But she'd struggled and built those up that she could function with them. So it's that issue about how much have you got left, and when do you lose a little bit more, and does that take you over a functional threshold? So that's why I tell that little story that always stuck in our memory. Dr. Waring and I and a few others that were around at that time.
Thanks, Fred. I think the way I look at it is more functional loss. I don't go get an EMG every week and see how much, can't measure it medically. But in 30 years, I've gone from walking normally to needing a cane to now I can't use a cane anymore. The balance is gone. I have to use a walker all the time. Used to be able to climb the stairs. Now I can't climb the stairs. Those are losses.
Yeah.
So if it took 30 years to get to where I am now, what's reasonable to expect to happen in the next 10 years?
Well, that's a good question. It's a crystal ball question. I guess, I wouldn't do an EMJ if it's not going to change what you're doing. But if you really wanted to know, you might get some insight, by doing it, because how much of a normal motor system have you still got? So it's already deteriorated, and now you're likely to stay at that stable level. The other way to look at it would be, if you're already using a wheelchair, then as long as you don't lose enough strength that you can't get yourself in and out of it to get up and still do a transfer, anything else, you see you're a long way. That's a bigger functional drop, a bigger hurdle to fall under. So that's unlikely. That's the other clue, and I don't know how good this clue is, probably because it's based on memory, and memory of things like how weak was I 70, 80 years ago is not going to be very good on a scientific basis. But we often wondered, you're never going to get worse than you probably were when you got over your fever and first were aware that you had residual paralytic problem from your polio. Some people, we used to say that to people, and then some people said, well, I was completely paralyzed. And, so it wasn't of any reassurance. But then that I was completely paralyzed, was that really during that period of time you were so sick you couldn't move? Just like any of us get the flu and we feel like we can't get out of bed. That's a different kind of a weakness than what a couple months, a month or two after the acute illness, then what were you like? That's what most of us would think would be the worst possible thing if, as we understand post-polio syndrome, all of that deterioration would re-happen again. I don't know how that makes you, how that leaves you feeling.
I don't feel any different than I did before, Fred.
No, but I mean in terms of worrying about it. How old were you when you had it again? I forgot exactly.
I had polio in 1953 at 5 years old.
5, yeah. So yeah, 5-year-old memories are, you have memories, but how reliable they are for things like the detail of how weak you are. It's kind of hard to know.
No, I agree. I was totally paralyzed at first, and it settled in my right leg. And a good bit of the time I was in the hospital, I was in a wheelchair.
Did you go home walking?
Yes,
And how long was that after hospital?
I think 4 months.
4 months. Yeah, right. See, so that's probably why you're not going to get that bad. You're totally paralyzed, but you could get to the point where you certainly are weaker because remember you're dealing with a much older neuromuscular system at this age, and so there will be a loss of strength. But hopefully you keep that up and you just keep minimizing it so that it isn't enough to leave you helpless. That's what you don't want.
No, then it also has to do with how smart are you with using what you have left. Don't overdo it. Don't underdo it.
Right.
Get the appropriate amount of rest.
And the appropriate amount of help from both devices and other people when that's what's called for.
Exactly. All right. Thank you.
Sure. Okay, thanks. So those are our questions on progression of post-polio syndrome. Okay.
Fred, Martha was able to join us late, so
Sure,
she's
I was
on the
just gonna
call.
go back.
If you want to circle back. Yep.
Before I got into some of the others. Yeah, Martha, I'm glad you made it. It was a question.
Agreed here in Kansas, and so frozen pipes, but now they're unfrozen. So thank you.
We're all dealing with it around the country in one way or another, this polar vortex. Okay, Martha's asking how to, if possible, distinguish progression of post-polio syndrome symptoms from pain and possible weakness due to lumbar vertebrae stenosis or nerve impingement from degenerative disc disease, I presume. She says L4, L5, and S1 stenosis, pain and weakness. She's currently says she's using pregabalin, a neuromodulator drug for pain, twice a day, and she's had epidural steroid shots twice a year. I presume those are being done for managing your pain, Martha?
To a degree, also, I call it the buzzy feeling. That is that nerve impingement kind of thing. And so it tends to address that pretty well.
Okay. So it's a discomfort kind of nerve pain.
Yeah, exactly.
She's 73 now, had polio at age 5. And you say you're using an AFO, ankle brace, on the left leg and a hiking stick.
Right.
And I'm remaining active. Now, how long have you had to use that ankle brace?
I've used it off and on actually since I experienced polio as a kid. And then there were periods through high school and college, because I've always been very physically active, I didn't use the brace. And then in my, early 30s, it was, an assessment of, okay, you want to keep fatiguing yourself, and I had a staple put in the top of my foot that really alleviated the foot drop when I was 13. So it really was my trying to get ahead of, overuse simply because I could walk. And then as the years have progressed, we've gone from the plastic and now I'm in the high carbon, whatever that, it's incredibly light.
Fiber, yeah.
Yeah, but now I am in the last year, and this whole back thing started the summer of 2024. So previous to that, I really had no issue. So sort of stunning to find out I had a 72-year-old back, but
Right. Well, that's why I wondered how long so the back pain is a relatively new problem then.
Yeah, and really that impact of what I feel like is weakness. So when we're talking about progression, and that is the challenge to see if you're at a point, because I've been traveling a lot over the last 6 years, and I overwalk a lot over various times, learn how to pace yourself. And that's really my concern now because of, there's a potential surgical, and I'm trying to read off my medical suggestion here, which would be, to do what do we say here? An L4 five posterior lumbar inner body fusion. Well, I'd prefer not to have to do a major surgery like that. If I thought I didn't get a return on investment, so to speak, that just dealing with post-polio progression, I need to manage. And cold is just deadly to my ability, as we all know, I think. I just got back from Belize, literally, yesterday, and today it is 79 degrees colder, literally.
Oh, I tell you, all pains are worse when you're in a cold environment. I swear.
Yeah.
That's been actually verified by people who've tried to look at that
Right.
scientifically. So I would say, back to your question, that the way to tell the difference, okay, usually you have a couple options. One is the issue of you can do an EMG at this point in time, electromyography study, even though it's not perfect, because if you're studying for the purpose of trying to decide is the new weakness in your left leg from PPS or a pinched nerve,
right,
it's going to be abnormal because you had polio in it.
right.
But there are some differences, but they're not as clear and depend much more on the skill and experience of the electromyographer than it is in someone who didn't have a polio history, and you're just worried, is a pinched nerve damaging the muscle in their leg?
Right, right.
Like, it is more complicated, but if the weakness is enough of a problem, then that can shed some light on it. Okay.
Mm-hmm.
The other issue I would say is the strength kind of the strength loss, the new weakness, pretty much the same all the time? I mean, in terms of it doesn't.
Yeah. And that's the challenge. About 10 years ago, I did have an EMG and a whole evaluation at Mayo Clinic in Rochester. So I do have those records, and we could do a, back analysis with the new one. And I that's something I'm on. And, it's just a strange feeling of, you're going and then you're like, not sure that's going to keep going. And it's a sort of fatiguing, and I think everybody knows that. You get a lot more pain when you've really over fatigued it in the muscles as it relates. And I have a very strong right leg, and I'm just trying to analyze expenditure of energy, because I am active. I want to be active. Fall potential, and I'm good about not falling. And I'm actually sharing something, and I will send it on to Post-polio. I'm in a research project with the University of Kansas on what's called adaptive CrossFit.
Oh.
And it is seated. And so it's been really valuable in terms of, I think, addressing my stability issues as it related to even my back pain and things like that. We have people who are paraplegics, quadriplegics, people who stand and have a variety of ways in which their mobility has been compromised, and of us are post-polio folks. So I'll share that information with the group, but that's what I'm just trying to get a clue on. How do I keep myself strong and still continue to be mobile?
What I was going to say was that, the other issue is if you're not having a lot of, or maybe you are, but it's like the radicular pain issue. If you're having pain that starts in the back and then shoots down the leg associated with, we're a lot more concerned that back issue. You see, the other issue is like you get a dramatic improvement after the epidural steroid, even if it's only for a short period of time. And then when that pain's under better control, you can use the leg a lot better. It seems strong. That would suggest that the back is a major part of it. Whereas if that is really pretty minor in the background, then it would suggest, and if you're when you do more, that's when it's followed by more weakness. Then you're more worried that it's mostly PPS. Might as well just wait out the back issue, because time does heal these things. If you're doing good therapy and keeping it stable and doing the right things. don't
And that's
abuse.
my question too, is what your all's experience is with people who actually do have these kinds of surgeries, because, you know, that's just a part of their back issues that they've had to resolve. And for people with polio, what kind of recovery issues are there related to having major back surgery?
I think you can't. That's such a general question. You can't
Okay,
answer. There's been good results. There's been bad results. You know, I think it all depends on the.
right.
It's awfully hard to
Yeah.
generalize. Right.
Well, I very much appreciate this group, and I really appreciate your thoughts on this. And as I'll send you the information on the
Yeah.
adaptive CrossFit, and I will just keep rolling along and try and be in warmer places more of the winter.
Well, keep taking care of your back. That's the thing. Let it
Yep.
back settle down, let it get strong and heal, and don't push yourself for a period of time. Okay, do yourself.
Oh,
Enjoy
I
those
do.
vacations without being active.
No.
Back in
Well, and you know, you don't want to sit around too much, because with back issues, yeah,
moderation.
don't want to sit, don't want to stand. There we go. Thank you very much. Okay.
Very good. All right, a couple of other questions. Diane Sprague is on has submitted a question. Are you on, Diane? Okay.
Diane's here, Fred.
Is she here somewhere? Okay. Well,
Yeah.
I'll go ahead and answer her question. It's pretty quick. She's asking about sacral nerve stimulators or bladder pacemakers. Have they been used for overactive bladders and been successful with polio patients? You know, I would have to answer that I'm not aware of any reports, nor have I known a polio survivor who had one of those procedures done and how they did with it. Overactive bladder, I'm familiar with the procedures because overactive bladders are fairly common, but I would not feel that overactive bladders are something that is more common in polio survivors. And if they have it, it's not because they had polio. It's a common condition as we grow older, and I'm sure there are polio survivors who've had overactive bladders, but I don't think it's because of their polio. It's coincidental. And I'm not aware of any reason why a polio survivor would have different outcomes than a non-polio survivor from those procedures. It may be that the overactive bladder down there, here's the caveat to it. What's the person? And I remember meeting you. I remember your name, Diane. So I think I've run into you somewhere, but I don't remember your situation, and you didn't put it into the notes. But unless a person had major mobility problems, like they were basically paraplegic and been in a wheelchair for years, and had to move themselves in and out every time they toileted, which is a challenge in and of itself, and then they developed an overactive bladder. It's that would be a slightly different, I suppose, situation in terms of what is the best way to handle it and what outcomes to expect. But
Fred, I'd like to just add, and it's just
go ahead. Yeah, then Mark, this is Dr. Yulberg, who's been on the call, and we gave her encourage her to say something if she's had something.
I mean, it's just an N or a number of one, but one of the polio survivors here in Colorado has dealt with all kinds of treatments for overactive bladder and did have the sacral nerve stimulator implanted. And she got about 50 to 75% improvement, but not 100%. Again, that's just one.
That's probably pretty close to the statistics, I think, in general for overactive bladder and sacral nerve stimulation. It's helpful, but it's not guaranteed to leave you fully continent and without any symptoms at all. Thank you, Marnie. You've seen it once in a polio survivor. There you go. Anything else you want to follow up with that question, Diane? Does that speak to what you were asking?
Yeah, I'm not sure she is on, Fred.
Okay. Well, she'll be able to hear the tape.
Yep.
If we hear from her. Okay, a couple more questions. Kathleen Casey. How are you, Kathleen? Are you on there? She's not on either. Okay. Kathleen. I remember Kathleen. She's from Portland, I think, Oregon. Hopefully she's not frozen out in Portland. Anyway, Kathleen had a question she submitted on talking to a friend that was 80 years old. And they mentioned that they had been, oh, that was the polio question. That's right. We started with that one. Okay. So we actually have had that. I wanted to say hello to Kathleen if she was on. Okay. Next one, seventh question. Melody Kane. Melody on the phone call?
She is on the call, yes.
Yeah.
Good. Hello, Melody.
Hello.
Thank you for your question. You wanted to know about osteoporosis medication and about should women take it. Now, I'm presuming you're a polio survivor.
Yeah, I mean, should post-polio women take it?
If you were specifically speaking to post-polio women. I guess the way, we have studied that question a fair amount. People have looked at it because osteoporosis is more common, or can be more common and more severe in people who are less active. Okay, so if you are not, because you've had polio residuals and you've not been able to walk a lot, or maybe not at all, then you are that's another major risk factor for osteoporosis. The question is about medications. The medications are when it's more severe, and we judge that by studies that are based on averages of normal aging women and men, if they're different norms for men and age, but they're also based on usually 3 bones are most of what the studies do. They're trying to pick 3 common bones so you're not studying every particular bone. 1 vertebrae and your hip. Sometimes only the 2 bones. Sometimes it's two hips or a hip and a knee bone. And the reason I bring that up is I've been aware of enough polio survivors who've had the studies, these bone density studies, and have gotten overly concerned about severe osteoporosis when they happen to have severe paralysis, paralytic polio involvement in the leg that was studied. And that is sort of a false narrative because the norms are not based on people who are polio survivors. They're based on normal people who've been walking all their lives and don't have other diseases. And so smaller bones that are less dense is an inevitability if you had childhood polio that left you with significant weakness in the leg. Certainly significant being if you had to use braces for any period of time, or certainly if you'd always had to use braces on your legs for walking, that would be very significant weakness, and you wouldn't expect the bones to have the normal bone density studies. So then if you look at them in your old age and they're abnormal, you're not as concerned about the severity. You're more concerned about the how much the bones through your vertebrae, because everybody, even sitters, have to have solid enough bones to hold our trunks up and our heads up when we're sitting. And so that number becomes a more crucial indicator, or you have to not go beyond looking at just the normal studies. So having said all that, the most important thing is to consider hormonal therapy, and certainly everybody should also be aware of vitamin D and adequate calcium intake. Those are the biggest ones that everybody needs to pay attention to as they get older, and try to keep that up. If you can keep your vitamin D levels normal and your and you're taking and you get enough calcium in your diet, and most people tend to need supplements to do that, then you're better off to do that and avoid the medications unless you're having problems with fractures, particularly spontaneous fracture. Then you need to get on medication. Or if the numbers are so severe, and that becomes a judgment call by somebody who's knowledgeable enough on both the tests and your polio and what that means based on what bones that were studied in the bone density studies relative to your paralysis pattern. If that's severe enough, then the person may well make the call that you would be wise as a completely preventive step to consider taking the medication. The reason I say that, and this is my opinion, because it has not been studied adequately in enough people to make stronger statements other than opinion statements, is because there are side effects from almost all the medications that are significant. And you can read about those. But they're not particularly, they're not without problem. Also, if you take them, I think more of the research relative to the side effects says that more and more people are saying, well, if you do have to take them for a limited period of time, like a year or two, but don't take them the rest of your life. And that's another way of minimizing some of the side effects with them. But they're not a slam dunk issue that they're going to give a guarantee to make you again not have fractures. Because remember, the fracture issue is only part of it. One of the issues, do you break a bone when you fall? One part of it is exactly how do you fall, the force dynamics relative to the bones. And secondly is the issue of how strong is the bone itself to withstand that force. And remember, any bone, all young, healthy people get fractures all the time because they fall in such a way the forces are just too high. What you don't want is to, osteoporosis prevention fractures is to try to prevent a fracture when it's a minimal force. It's a mild fall. It's a fall that most people wouldn't hurt themselves from, okay, or certainly not have a fracture from. But if you have severely osteoporotic bones, they're very fragile and they will fracture that. That's what you're trying to prevent. And so that becomes a complex, again, judgment call as to when do you take it. But I certainly, the way you had put your question, should all women take it? Polio women be taking medications? No, I would not think that they all should be.
Thank you. That was helpful.
Thank you. Okay, and then the last question I have pre-submitted in writing was from my old friend Barbara on this is a sect out in Tennessee. Last I knew. Barb, are you on the call? She and her husband Ron were good friends of ours for coming to the Bay Cliff polio retreats.
Yes, I'm on the line.
There you are. Good to see you. How are you?
Good to see you too. Great.
Hey, there? Good, Barb. So Barb's question is that she recently says that she had a Doppler test on both of your legs from the knee down. And the polio leg showed a noticeably lower, poorer blood flow from the good leg. Is there anything that can be done about the poor blood flow? That's a good question, Barb, because it's, again, another one of those questions like the osteoporosis question, that what to do about it is not so black and white. Because if you had polio, again, particularly if you had polio as a child that was significant enough to leave you wearing a brace,
Which I do.
yeah, which I think is you, if I recall, your one leg. Yeah.
Yes.
Yeah, that the arteries to that leg are going to be smaller than normal, because they never grew adequately because there wasn't enough muscle to call for that much blood or whatever the exact reasons are. But they aren't as big, and so they look atrophic. But if they're not, don't show clear other signs of irregular narrowing, so to speak. That's what you get from arteriosclerosis. That's why they usually do them. then I'm not sure that taking medication is going to do anything. And frankly, even in the people who that is what they have, and then they're going to treat their cholesterol levels and things like this to prevent, the cholesterol narrowing of the arteries and blood flow compromise. The other strategy would be blood dilators, so to speak. And those don't work terribly well usually, but occasionally there are people that get some benefit from those two. Those are your only two other approaches other than considering surgery. And certainly surgery in a polio survivor who's got small arteries because they had the long-standing paralysis probably is, results would be pretty questionable how reliable the results would be. So what were your symptoms that provoked the need to do the Doppler, Barb?
My doctor just had an interest in knowing what the blood flow ratio would be from one leg to the other.
Uh-huh. So it was more of an interest issue, yeah.
Yes.
Yeah. Do you have a lot of problems with polio feet, so to speak, the cold blue feet?
Oh, yes.
Yeah, you got cold weather in Tennessee, I suspect, right?
Oh, we sure do. It was 21.
21. Oh, well, that's pretty warm. But yeah, no, it's cold enough to bring on that, especially if you're not in a nice warm place. But I would say, you can have that even if your arteries don't look normal, and polio because it's more of the vascular control. So you have another factor that contributes to that cold feet issue. But sometimes that's what made people worry. But you've not had open sores or trouble healing anything on your feet.
I have not, no.
Well, then I would just say thank you very much. That's interesting. I would expect my arteries to be a little smaller.
Thank you.
Good. How are you and Ron doing otherwise? Good?
Ron's well.
Good, good. And enjoying your new home in Tennessee?
We sure are.
Good. Okay, everyone. This is our Brian. I'm going to turn the thing over to Brian because if any of you have submitted questions in writing to him, he will be able to give those to me next. And if there's anything else, then if there aren't those, we've got about 20 minutes left that was scheduled, and somebody can wave their hand if they have a question they'd like to ask more spontaneously.
Nope. I think we just have one question in the chat from Peter Way. He said he's interested in knowing if vaccination with IPV, although it can't kill vaccine-derived OPV virus, would cause the virus to replicate less in the gut of that individual and shed less into wastewater.
Very good question. I do not know the answer to that. I'll punt to Dr. Yolberg, who's an active Rotarian and keeps up on all the latest, but that's a good one. You want to hear it again, or did you follow that?
Oh, I followed it. So IPV does not induce gut immunity. That's OPV, the oral polio vaccine, does. And that's one of the advantages of using OPV is then people, when they're exposed to the polio virus, are not going to, after their first dose of OPV, are much less likely to shed the virus in their stool and potentially out into the environment and be a risk to other people. The IPV induces antibody response so that if any polio virus gets into your bloodstream, it gets attacked and you don't get the paralysis. But IPV does not induce any kind of gut immunity. But in answer to your question, Peter, also, IPV still will prevent paralysis from one of the circulating vaccine-derived polio viruses.
It will. Good.
It will.
Okay. Brian, I think I just saw another question flash by from somebody.
Yeah, I think Ronnie Morse had a question. Ronnie, if you want to just unmute and go ahead and ask.
Say it.
I
Go
did.
ahead.
Hello, Doctor. Dr. Maynard, you diagnosed me in 1984, I believe,
Wow.
uh, at the University of Michigan clinic that you ran. And thanks, it might have been since 88. I've seen you. You gave me a prescription for my first AFO, and it's been helpful, and I'm eternally thank you for that. It's prevented some falls and really kind of changed my life, so thank you. I have a question now. I'm scheduled at U of M, and I'm still treated at the post-polio clinic there by Dr. Laylau.
Okay.
And I have a question. I'm scheduled for, and I typed it incorrectly, and I'll probably pronounce it incorrectly. I'm scheduled for some autonomic testing through the neurology department. Um,
Yeah, isn't that spelled with a PNUN? That pneumonia? Is that
it's a nerve, like a nerve test. They put you on a table, and they do your blood pressure up, and move you up and down, and
okay?
it's to test for a lot of peripheral neuropathy.
Neuropathy? Yeah. Are you having trouble maintaining your blood pressure when you're up?
It's yeah, it'll drop occasionally, and it'll at times I'll get tachycardia, just like sort of out of the blue. It's also to test for, as I understand it, and maybe you can expound on it a bit, issues with vagus nerve issues.
Mhm.
I also have Crohn's disease, and I've had three small bowel resections. And so I've lost a lot of digestive motility, which the gastros at U of M said this is also compounded by the polio issues. Um, so now I can only eat pureed foods, small amounts. And they also did some testing, and I don't know if other polios have had this impact, but I was told it's common in polio patients and in ALS patients and MS patients that actually have paralysis on the right side of where my polio manifested. In the anal sphincters, they don't dilate. So I have to go into pelvic floor therapy and get frequent dilations. And also through the urology department, I have to take medication. And I'm told again, it's from the polio, that the lower valve doesn't open correctly. So I actually am taking low dose Valium for that. And again, the urologist said, yeah, very common in post-polio, very common in MS and ALS patients. But the primary question is the testing. Do you have any experience with post-polios that have had this autonomic testing or whatever it
Yeah,
is?
I haven't. That sounds like something relatively new, or at least the way you're describing it. The best. I haven't heard of that being specifically done for polio patients. It sounds to me like they're worrying about your autonomic nervous system, is what
Right,
they're
right.
and and in the sphincter issue, I'd be pretty skeptical about that having much to do with the polio because, there's always been said that there's never been clear evidence, to my knowledge, that polio virus, when you had bad cases, affected the directly the autonomic nervous system, the smooth muscle. The autonomic opposed to smooth muscle, the sphincters are smooth muscle, and the external anal sphincter, you've got both. I mean, there's both the smooth muscle component and some voluntary one. But
They actually did a test.
wouldn't get spasm. I mean, the polio wouldn't even more likely to get spasmodic and not open.
Well, the curious thing is when they actually did the test where they insert the balloon and they inflate the balloon and then you go through the constriction process. The
Right.
right side was significantly weaker than the left side. And when they've done the rectal dilations and then the probes, they've told me you have significantly less muscle strength, less strength, and a lot of trigger points on the right side, but not the left. So, I mean, that's It's like I haven't heard of anybody else having those kind of issues.
Yeah, no, I haven't either. Yeah, that sounds like a unique one. Well, I'm sorry you're having so much trouble. Yeah, it sounds like it's a different kind of a process superimposed, that's just complicated by some of this polio history, whether they react the same to the primary, the Crohn's.
Yeah, the
Uh,
autoimmune has quite, and I also have rheumatoid arthritis, so that kind of complicates some of the issues.
and then you're probably on drugs that are trying to help those conditions that usually affect the immune system too.
Actually, I couldn't use the drugs because of the side effects.
Oh, really? Okay.
Yeah, yeah,
Fine.
yeah. Anyway, thank you.
All right.
And
Well,
thank you what you did for me back in 1984. It's been a lifesaver.
sounds like hopefully you had some 30 good years anyway.
Oh yeah. Oh yeah.
Good. Good. It's always nice to see old friends. Okay.
Bonnie had a quick question. She asked, what does severe demineralization of the spine mean?
Well, that would be the loss of calcium, a calcium matrix in the vertebrae. That would be demineralization, is really a loss of calcium, calcium phosphorus, which is what our mineral makeup of the bones are. And so that when they see an X-ray or a bone scan study, a variety of studies that are used, they would see that. That's the way they would describe it, I guess. And if that's the case, then again, you have to say, if they're already wedging and collapsing, even without falls, which does happen just from position, then in the studies, all the measurement numbers are all pretty poor. That becomes a case where one would have to take a serious look at the pros and cons of trying some of the medications that are available.
And I believe we have one last question here from Wendy Wilmer. Wendy, are you there?
Yes, I am.
Yeah. Back to it.
So, did you want to read it, or shall I just
go ahead.
read
Yeah,
it?
you can just ask it. Yeah.
Okay. First of all, thank you, Fred, for being part of this. I only met you the once at Warm Springs, and it was a great experience, very vivid. I remember breaking into the swimming pool. We were very naughty and removed the cover from the so a little sort of ninja polio survivor action. My question is, and it's really sort of crystallized around a lot of the conversation that you've had today, particularly as relates to recovery from surgery. Sometimes, that it creates a trauma that is will impact your independence, mobility, et cetera, et cetera. Just to recap, because I don't expect you to remember my story after just a couple of weeks. But I had polio at age 8 months old in 1952 and made, at the time, apparently they said I'd never sit up or walk. And in those terms, I made a phenomenal recovery. I did have one surgery for a multiple tendon transplant in 1957 or 58. I wore the metal braces with the ugly brown shoes below the knee. So the knee has always been stable. And in more recent years, I was diagnosed with post-polio syndrome in 1984. So it's been a long journey. And, by through the National Rehabilitation Hospital in Washington, I've had outstanding care, in their post-polio clinic and their PTs. Now, what has happened is in February of 2022, I ended up in the hospital with severe aplastic anemia. with at that time that I was admitted, I had a platelet count of 6,000. So I've come a long way. Very grateful to Johns Hopkins because I was treated there. I was given ATG therapy, and I am transfusion independent and have been for almost a couple of years now. So I'm very grateful for that. But what has come up is the question of I have an ovarian cyst. Now, the doctors, the surgeries and the surgeons and all that want to, remove it because it's over 7 centimeters in size. And my platelet count is now up to, as of yesterday, 91,000, which is amazing. And I'm very grateful to that. I do live on immunosuppressants and will do for the rest of my life because of the horse serum therapy. But I'm worried about, they talk about the laparoscopic surgery and all of this, and that's wonderful. But I have had 2 C-sections and a hysterectomy. So I'm concerned about they might have to go in and it might have to be an open procedure. And I'm concerned not only about blood loss and all of that, but recovery from that type of intervention, because that would be a pretty major surgery. And do you have any thoughts on that?
Well, I guess one thought I would throw out to you is, the laparoscopic should be without trauma. I mean, it's short of some huge bleed problem that obviously they were worried about and were trying to prevent. But if that didn't happen, the incision itself, you're really just talking about the incision. And even if it came to where they had to open you, I would think a unilateral cyst, a 7 centimeter cyst, would still come out through a very small incision. It still wouldn't be a very, more than perhaps 2 or 3 inches. I'm not a surgical expert on that, but that would be my impression. And they would probably do it in a horizontal fashion through the abdominal wall, which would be the least traumatic way from the standpoint of weakening that abdominal wall. And usually after an incision like that, you're not, in most cases, I would think the pain would not be that great. You've had probably much worse.
Oh, yes, I have dealt with a lot of pain.
You wouldn't be overly limited by the pain, and they would want you to be up and trying to walk and do your normal activity, just like they would for anyone else, as soon afterward as possible. Are you still ambulatory? I mean,
I'm ambulatory, but a lot less than I have been in the past. And part of it is I've got some pretty hefty deconditioning going on because I quite frankly have not had the energy. I mean, when you've got hemoglobin at 7 and platelets at 40 or 30 or 20 or 10, you don't have a lot of get up and go and pep. So I have recently just started doing some TheraBand exercises for my arms and neck and shoulders, but my trunk is very deconditioned.
Nevertheless, I don't think that surgery, even if it came to that they had to open that, to do the open removal of that tumor, it shouldn't leave you without complications. It shouldn't leave you debilitated enough that you couldn't, at least with someone helping you, get up and walk around to go to the bathroom or the short distances in the hospital and continue something of that sort, if not more, over the following week or 2 or 3 when you got home. And by 3 weeks you should be able to. You shouldn't be limited by the surgical problem. Okay. be back to where you are now, maybe. But I mean, that's a slightly different issue. But I don't think I'd let that stand in the way. It probably needs to be taken out if you've got that 7 centimeters, a pretty good sized one. And
Yeah, my nephrologist said it's the size of a kidney, so it needs to come out.
well, that may be the problem. Hopefully, the incision isn't too big.
Thank you. That has been very comforting. It's very, very helpful to know that, because I've always had a very conservative approach to surgery in general. As you can tell, I only had one surgery that was polio related in my life, which is really quite remarkable. So, but that region has been somewhat beaten up over the years.
Oh, well, it's resilient, though.
We hope. Thank you so much. I really appreciate it.
It's nice to talk to you. Well, I think that's our time. So thank you for joining the call. Hopefully it's been helpful. And I wish you all a warm rest of the month. Keep warm. Take care of yourselves.
I'd like to thank you, Fred. You do a great job. You help us all out a lot. Thank you, Brian.
Absolutely.
Thank you, Dr. Maynard.
Diane, good to see you.
Good to see
Have a
you.
nice afternoon.
Yeah, thank you everyone for joining us. Some really great questions. If you have more questions next month or the following month, be sure to look out for the sign up email and you can join us again.
Thank you, Dr. Maynard.
Okay.
Hey, Bonnie.
Bye-bye, Bonnie. Yeah.
Thank you. Bye-bye.